So thanks very much for asking me. When I think about depression, medication, talking therapies, you know, what about it, the ongoing debate? Just taking a straw poll, when anybody here hears on television or radio, drugs, they only are interested in drugs, or talking therapies, you know, that's the way forward. Any immediate things that spring to your mind that concern you or that interest you?
Side effects?
Absolutely. Anything else?
Other therapies.
Other therapies, yeah. So hopefully tonight, when we look a little bit at depression, is it medication, is it talking therapies, or other therapies, as you say? And if we are considering the important thing of our own mental health, and if we're going through a period, or a loved one is going through a period of depression and suffering intensely, as one does with depression, we want to have the best, don't we? We want to have the best advice. We want to have the best professional service. We want to have the best hope, the best outcome. And as we all know, depression isn't just a bad day or a bad mood. Depression is a pretty awful state of mind where one is really low, not enjoying normal things, in an absolute agony. You think of J.K. Rowling said, you know, she'd give up more or less anything to do with all her fame and fortune because she'd never experienced anything as devastating as depression. And, you know, this is real, and the pain of it is real. So it's very important, as we hopefully know more about treatment and hope and the future, that we become as informed as we can be. And that's not easy. I think we'll all realise that. I mean, we're in a nice facility here. We have an opportunity to be able to look at online information. We're in a country where people are now talking more openly about it. But even with all of that, I can think depression, and I think, you know, in all my years of experience, each person is also different. So it isn't a matter of one size fits all. It isn't a matter of popping into a GP, and perhaps you'll have a GP who will have time and interest to be able to talk through what you're experiencing. But then you may also have somebody that says, you know, that the service they belong to gives them something like 8 minutes per person, and all of a sudden you're supposed to spew out the appropriate symptoms, get the appropriate tablet, and we know that that's actually unlikely to work, or is it? And hopefully we'll broach that a little bit today. Also side effects, and I suppose one of my thoughts in depression and treatment is, yeah, we need to know about side effects, and we need to know about benefits. And we need to know about side effects of talking therapies or alternative therapies, and we need to know about benefits. One of the things I say to people if we're coming to a decision about taking something like lithium, where you need a blood test and you need to check your kidneys and check your thyroid, one of the things I say, and people get a surprise, where I say, well, actually, it's thought to be neuroprotective, in that I remember running a lithium clinic for older people every 3 months. And I used to be fascinated as to how little memory problems people were encountering. And my supervisor at the time said, well, actually, there seems to be evidence, and some evidence, that it's neuroprotective, so that you're less likely to get a dementia syndrome. I said, well, how come we never tell anybody the good news as well? Likewise, you can have a depression, but people have this idea that I'm stuck with mental illness, or I'm stuck with staying unwell because I've had a few bouts. And actually, we now have knowledge that particular type of psychological therapies, or with trauma, particular type of other therapies, lead to a change, not just in the way we think or in our brain chemistry, but in the way we react and think about ourselves, so that there can be more hope at any stage. We don't have to be stuck in a rut. And I think it's very important. I know Pat McKeown, who started to wear many years ago, he used to always say to us as SHOs, he'd say, always keep going. There's always something you will find which can turn the thing round. And that's terribly interesting for me. So depression, medication, talking therapy is an ongoing debate. If you're like me, and I feel passionate about the fact that people can recover and people can live with things that are difficult and have a quality of life, I feel very passionate about that. So when I hear blithe answers, oh no, 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 pick yourself up and you shouldn't be taking a medication, as if there's some blame, or no, 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 you know, talking therapies are useless, it's all an it sort of angers me, because it's not that simple. And people's lives are not that simple. And you don't go to a doctor at a point, or a psychiatrist, thinking, okay, it's going to be that simple. Because actually you have to say, well, why have I got sick now? Or why again? Or what is happening for me right now? And we know that as a person, we have relationships. As a society, we have work, money, issues, all of that. So all of that comes to bear on whether we can recover well. And that's important. So why, and I'm allowing myself a slow start, so to speak, before we get into the evidences, because for me, after many, many years, decades as a doctor, I am constantly fascinated by, no matter what you do or what you actually work with a patient, and indeed with anybody, is that no matter what's about, your outcome is very determined by whether a person feels in a safe place, whether you feel you can trust the person that you're disclosing your inner world to. I don't know if you agree with that, but I think trust is kind of vital. In the 80s, I was working in something called biofeedback clinic, where we literally wired people for sound. So you had a skin response, which people would call, is that, you know, the lie detector test, but it's for stress. Little EMG on your neck to see how are you for muscle tension. Little skin temperature to see, you know, your gut responder, or what way do you respond. And I used to be fascinated that no matter what a person suffered with or what kind of personality they were, there was one particular technician who used to put them on that people always did well with. They always began to feel better, the stress went down. You could say, was it because she gave a half an hour, or was it because she was an empathic person? So at the end of the day, it's terribly important, actually, to have some kind of sense that one is understood. That can be a friend, a partner, but when it comes to the doctor-patient relationship or the therapist-patient relationship, I think that's terribly important, because there is a power to that. I'll come back to the picture there, which I sometimes show, that's up at the side. So it's science involved in mental health, but it's also an art as well, because the very fact of having a safe place to process and make sense of what it is you're experiencing, that in itself is very powerful in healing. And, you know, I don't know, I think it was last year the National Geographic did a front cover on placebo works. And actually when you went into it, you could say to somebody, I'm giving you a placebo, but, you know, take it for a while and you'll feel better. And they began to feel better in many cases. Why? Not because it's voodoo or you're just whatever, but actually that very safety creates its own physiological response of ease, lack of stress. The way I look at it is, you know, if a single bar of chocolate can give you an endorphin, what can that feeling of interest, safety, we can get through this will pass. Remember Christy Moore describing, after being a year in bed, he said this publicly, it being a year in bed with depression, the very fact that his wife thought we'll get through it was that thought, or that thread with hope. And then he'd always be asked about it afterwards, and I remember my amusement when he said the worst thing about depression is having people to keep asking you about it when you actually want to leave it out of your head. But it's an interesting one, and for us it matters. So what I think is, believe it or not, having been in Kruger Park in South Africa for the first time just a few months ago, a wonderful sense of space, and looking at the giraffes, it reminded me that many years ago I'd worked in something that was called giraffe therapy, of all things. And it was because the giraffe has the biggest heart in the animal kingdom, the longest neck up above the foliage in the trees, 2 ears and 1 mouth in that order. And many times when we use what we call giraffe language, a bit of heart to be in the space. As I say to people, don't just do something, be there, stand there. 2 ears to listen. Are we truly listening? Because I remember the first time somebody said to me, my father died. And I was going to, and I said, I can't remember if I said or was going to say, I said, oh, I'm terribly sorry. And he said, oh, I'm not. He was really harsh. And it taught me to listen, to wait for the response, to know that my experience of somebody is not somebody else's experience, and to be able to listen. Very important, because sometimes with depression, we shut off from people why and what is happening. So before ever we think whether we give a tablet or create a space or have a particular type of talking therapy or alternative therapy, we have to have in itself that connection and that heart. Now, we all know a care assistant, a nurse therapist, CBT therapist, whoever it is, may be the person that helps change things round because they get us or they get something. And that's very powerful. So again, you know, there are different strokes for different folks. Some people say, I just can't get, you know, you mightn't like authority, and therefore somebody who's a little bit authoritative or bossy just creates a block. So have a quiet confidence in oneself, in one's ability to process and know and be open and to think this helps, or this works, or this team works with me, or that doctor works, or that psychologist, but the other thing doesn't. And we don't have to overthink it. You know, to have a quiet confidence that your gut tells you certain things. Years ago, I worked a lot on medical education, and so it's interesting because therapist empathy is the key in the active participation of the patient in treatment and a predictor of successful outcomes. That's the reality as well. You know, the instrument has to be good. You can't have a blunt instrument, or unless you like blunt instruments. And again, that's very important. So we need shared decision-making, shared emotional and physical space. Psychiatry is one of the things that the great Anthony Clare said to us when we were learning. He said, if you can ask something tomorrow, put it off until tomorrow and listen today. Now that fascinated me, because I think it's true, we can't hurry along jolly to conclusions. We must get the story right to start with. And I thoroughly believe that if somebody is suffering from depression requiring a psychiatry and an assessment, then time, thinking, letting the story emerge is important. And with oneself, to have patience, massive amounts of patience, as one works through what is in fact misunderstood by many people, and sometimes in our own heads, we're full of judgments. You know, you should have got past this now. Oh, that's very silly. Those of you who have experienced compassion-focused therapy will know, Gilbert has written a lot in it about it, that actually, you know, you may not even realize that you're putting yourself down, criticizing yourself, the inner teacher or the inner whatever, punitive dad or mum or critical of something else. And that, just think, if you're constantly putting someone down, if you're constantly putting an animal down, it's going to sit down and cry and cower and lose confidence. So we have to fascinatingly work as well on creating, if you like, different, I call them different neuronal pathways than that critical inner sense. So we have to have shared decision-making, shared emotional and physical space. And there's psychological reactions to illness, isn't there? There's a lot of studies that say, for example, people who have been diagnosed with, say, breast cancer, that actually those who either get really mad and angry immediately or maybe deny it have better outcomes than the people who hear it and say it's all right and are very stoic. And I'm fascinated by that. Because again, you know, why I'm sick now, allowing us a certain space, but we may also need treatment, even though you understand why you feel that way, because I've just had a hard diagnosis, or I've just had to get my head around something. And a wonderful lady through my day hospital recently, and you know, at 55, she got a whole rake of physical illnesses, which meant she loved playing an instrument, she couldn't use her hands like that. She loved walking, she couldn't do that. She planned a retirement, she couldn't do that. And people were thinking, well, gosh, that's terribly understandable. But just because it's understandable doesn't mean one doesn't need help or treatment to work through or transition the grief with regard to health that was gone, the loss of that, and any link or opportunity to what I can link with now to give me quality of life. And actually she's gone on, so her head is fine, to study something that she always wished she did to start with and is getting hours of pleasure out of it. But it doesn't come overnight. One has to be able to have a space to process some of this. And there are therapies that look at depression that work better for loss than for other things. So it's again interesting. There are psychological reactions to illness, physical or mental. How did I end up like this? What about, you know, you can have a depression with psychosis. What's psychosis? It's a total break with reality. People absolutely tortured with, it is totally my fault. It's my guilt. A delusion of guilt is very hard. I remember treating somebody whose father had taken his life, and she said, I killed him. Now, she believed she did because she had a minor irritable reaction 4 months before that happened. A sensitive person who was always kind and good, she could not forgive herself for that. And then when you're in a low mood, you've got a black view of everything to a point where you believe it's so fixed. And in those ones, it can be very useful to have a medication which dampens down the intensity of that self-hatred. And then we worked on psychotherapy, and you know, she's doing very well. But that fixed quality, you've had people who have terrible delusions, they're being persecuted. People who feel, you know, that definitely my insides are rotten. I am dying, I am rotting. It's a total belief. What would the man in the street view be? And I always think of those kind of sentences where people say, he's not himself at all. He needs a spell inside. He's not well. She's back to herself. And they're kind of nice phrases, actually, because they're a bit more accepting than we can be sometimes of ourselves. The wider context of reality. Yes, illness, suffering and death, they're part of the story of life. Do you ever think looking at magazines and you sort of say to yourself, oh God, has everybody got the perfect life with the 2.1 kids, the mortgage, the house, and I don't know what else? And then you look and so, you know, and you think behind people's lives, there's so many stories. So that story of life. I have an occupational therapist and she looks as a treatment for depression at meaning, at context. What's the meaning for this? Some people have a spiritual meaning. Some people say, there's nothing I could do about it, but it is my life. And they become an agent in that. So how do we fit that in? The helplessness when you can't lift somebody else out of something. How do we get back a sense of control? And these are ways, when we lose control and we feel helpless and we feel hopeless, that's when depression is maintained. Seligman has a book, Authentic Happiness, which, you know, sometimes when I hear that I think, oh my God, and I hope, you know, no offense to Americans and be very positive, but is it an American book, Authentic Happiness? But actually, it's really good. When I was reading it, it made me think that when I went to college, the same Seligman talked about helplessness as a model for depression. What maintained you depressed was this helpless, it's out of control, hopeless feeling, and how to break it. And again, some of you will have heard of some of his studies. I mean, you think, oh, I'm sorry for the actual animals involved, but he had animals in a glass cage and they had to jump, they were trying to jump out of it and they got electrocuted because it was some clear glass or clear something. So every time they tried to jump, They got a bang and they ended up back in again. And in the end, even when they took away the exit thing, the thing that was blocking them, when they took it away, the poor animals didn't jump. They were depressed. And it was quite a good model to understand that if you get a lot of knocks one after the other, you can become quite helpless and quite hopeless. Or bullying is a very hard atmosphere, isn't it? It's a very, very insidious kind of experience. And so that was a model of depression that we use in CBT, IPT and others to help people get a sense of control, get back at some agency. However, years later, he went back to look at the fact that there was a large number, there was something like a third of those animals who, when he took away the glass thing, they jumped. They never gave up hope. So this was an interesting thing because he's written about resilience, you know, that as we say, there's illness, there's suffering, there's death, but I've got through this. As I say to people when you're in recovery, that was in the past. I have a distance travelled now. You can have a bad day, but you're not going back to where you were before. You have different tools, you have different skills, you have different access. So it's very important to have a sense of agency, control, and hope that there are things that can break that. If you have a well-meaning friend who says, just snap out of it, and you think, well, I can't wash my hair, I can't get up, I can never mind run down the road, well, then what you need is a therapist who works in something that gives you, again, a feeling for the first time in a long time that actually you're not helpless. So they might say, I just want you to get up and I just want you to pick the comb up and comb your hair. That's all I want for this week. And maybe you say, well, that's what I did. And you say, well, I did that. It might be the first time in a long time. And you mightn't do anything else. Sounds simple, sounds crazy sometimes, but there's a study, there's behavioural activation, or that goal has been looked at as a model. And if we do it within 2 weeks of somebody being an acute inpatient, or if we do it at outpatients, it cuts recovery rates completely by half. People recover faster. So there are psychological reactions to illness, anxiety states, depression, uncertainty. We all say we can deal with stress, believe it or not, if we know what we're dealing with, but you're uncertain. You don't know if the job is coming or going, or if the mortgage is coming or going. So we search. So loss of control, sense of failure, stigma. Do you think stigma is big or important? Isn't it? Yeah. Because it can be very subtle, you know. It can be very subtle. And we like to think that we're open. But I suppose what strikes me again and again is, like I would, because I work in the independent and private sector, I've worked in the HSE as well, but you see maybe more doctors or nurses, and really it's very hard, because they're saying, well, imagine if I admit to this, then I look like I'm failing, or I look like I'm failing somebody else, or I have to report myself to the illness section of the medical council, and you know, so that's difficult. But then you have others saying, oh, I always thought you were well able for it, and it's sort of looked as a sign of weakness. Or you think, I don't want to be like my father or mother because I remember them lying in bed a lot. So we give ourselves that stigma. So stigma and overcoming that mark that seems to be there. When we had it maybe 20 or 30 years ago for cancer, didn't we? And then, you know, people thought, I'll catch that. But actually, as we know, it's not a diagnosis, a fatal diagnosis in many cases now, that we can do a lot for it. But you don't blame somebody for it. Secretiveness and collusion. If we could break isolation, we wouldn't need half the amount of things that we take. So that kind of secretiveness, isolation. I find group work is fabulously powerful, not because of group psychoanalysis or group psychotherapy. No, it's because the person says, do you know what, I'm not barmy, I'm depressed, or I'm OCD, or I have had a psychotic episode, but you know what? I'm a normal human being. This doesn't define me. This is something with an illness. Very, very important. So overcoming that. So there's a powerful effect of simple psychological intervention, facilitating self-disclosure, exploration of emotional issues, any acute stage of illness. So that's protection against later emotional distress. I remember Anthony Clare saying to us, don't take away one defence until you have something else to replace it. In other words, don't analyse something and say, well, actually, you know, there's the overprotective husband and, you know, there's the dependent wife. We say, well, actually, if it's working for 20 years, maybe it's only stopped working because she's depressed. Why? What is that? You don't suddenly, because during that dark period, you may have an insight into things that have changed, but you may just be looking at them through dark glasses. So it's terribly important to explore the emotional issues and look at that and think, why? You know, that worked well before. I find that people who've experienced childhood sexual abuse may have coped, and then they blame themselves when they get depressed by saying, oh, well, you know, that was all a lie. You say, no, it wasn't a lie. It was a coping, but maybe it was a secretive, an isolation, and how do we work through that now? And it might be that the person only now is able to look at it because their child is the same age that they were, or they've heard something on the radio or television. And I've had people in their 60s and 70s only have a language now. I had a 70-year-old man recently who said, I'm enjoying things for the first time ever. And I admire him because of his capacity to enjoy things now. And we're building up, his physical health is now better than ever it was. So it's important that there's a powerful effect sometimes of that psychological intervention of having a name for things. Because fears can run into obsessions, or anger can run into depression, whereas if we say, I'm happy, I'm sad, I hold it, I learn the skills to manage that, it won't define me, and I can begin to move forward. So there are specific behavioural and cognitive strategies. Deep muscular relaxation can control anxiety. Now, some people say, oh, I don't believe that, that's too simple. I think there was something that they have, I don't know if it's the Old Testament, the New Testament, or something in the Bible about a guy who went for miles and miles and miles to get some cure, and instead he was told to go down and bathe in the river and his leprosy would go. And he got raging, because he was ready to give gold and silver and cows and sheep and I don't know what else. And somebody said, well, if I asked you to do something difficult, you'd do it. And he went and bathed and he got better. And I think sometimes, you know, the actual break, people wake up in fear of the day. People have anxiety and haven't learned that this is my body building up and building up, and next minute I've just blown up at something. So the actual thing of relaxation itself, what I call to people square breathing. Breathe in to count to 4, hold it for 4, breathe out for 4, come back for 4. And there they are, square breathing. And you are breaking the hold of that fear that's driving the obsessions, and so, because you can't really concentrate on your breathing and concentrate on the thought in your head. I think as you were saying very much that, you know, next month there's something on mindfulness. Now, it's not the answer to everything, it doesn't suit everybody, but it does really help in a lot of cases. And it's because he said, don't believe everything you think. I think that's what you're going to hear about next month. So our giraffes, with their long neck, to take their time above all the foliage, to look, hear, listen, respond. Giraffe language is the opposite to jackal language. You never do this, you never do that. Biting back and having the same conversation and conflict. That reminds me of South Africa, so I'll have to go again sometime with a beautiful space. So stay human, as I said. Translate a person's anger or aggressiveness into unmet needs. You know, you may have a friend who's suffering from depression, and because they haven't jollied along and got better because you've suggested X, no point getting angry. And come on, I spent that with her, I'm not spending any more. Just recognise you need a bit of time for yourself, sure. But we don't help in order for the outcome. You get better this way. So translate anger into an unmet need underneath. Yeah, what's happening for the person. Stay connected, because we need empathy and other people need empathy. So depression, look, you know very well, but I think when we say it's a state of low mood, it has to be a couple of weeks. The ICD-10 International Classification of Diseases says a couple of weeks at a time, but only a couple. So people spend years in bad states before they recognise that they need help. Thoughts, emotions, behaviour, sense of well-being. Sadness, anxiety, hopelessness, guilt, worthlessness. Sleep, appetite, memory, concentration and energy. Loss of pleasure. Negative thoughts about oneself, the others and the future. Suicidal thoughts, self-harm. Delusions and hallucinations. Do people relate to that as a sense of depression? So it's not very nice, is it? And just 3 of the symptoms, being low mood or a pervasive sense of sadness, what I find a huge, huge help in picking it up in people, it's just not enjoying things that you normally do. Because recovery isn't about getting a Nobel Prize or, you know, flying to the moon. Recovery can be to go out and say, oh, the sky's blue, or that was a good cup of tea. Well, that's interesting, I might do that. I'm fascinated by that. I have a lovely farmer who comes to me, and I always know I can't remember the names of my cows. Now, I couldn't remember the name of a cow to save my life, but he loves his animals, and he's not getting the same yen or interest when he goes out in the day. And when he gets better, he knows them all again, and he's interested. So it's really fascinating, you know, what your quality of life is for you. So I think, again, you know, it's not nice. Some people, I keep saying, like, sleep goes off, early morning wakening. Oh, I can get to sleep, but I wake up, and in the day, it's just horrendous because I'm fearful. I'm fearful of everything in that day. And I always think, again, we're animals as well. You know, you want to be healthy animals. So that's why with some people may say, oh, I don't want a tablet. Somebody might need a tablet for a couple of weeks to break the cycle around sleep. Because you know, when we don't sleep, we get pretty irritable and low and depressed. And we are physiological animals. Now, I don't mean lack of sleep because you've stayed up all night doing video games. I mean sleep where you know, can wake up and you're terrified of the day. Terrified. And, you know, that's a horrendous. And that's the time when your cortisol or your hormones are at their lowest. And they rise during the day. So again, you know, that, the lack of appetite, the loss of weight, or the putting on weight, you know, we're physiological animals. So depression is not a very, very nice thing. And in the old days, we talked about biological depression, and then we talked about reactive depression. And it was a bit like biological was the real thing, and reactive wasn't so much the real thing. But you can have both. And if I feel low and poor mood and no energy and disinterest in things, I am going to isolate myself. And if I isolate myself, I am going to feel I'm kind of unlovable and nobody's interested. And then somebody comes along and asks me to do something, or the phone rings or something, and I react, or something bad happens and I have no strength for it. So I prefer to think as our depression as that state of low mood and sadness for weeks at a time with disinterest, which can affect you in your body, can affect you in your thoughts, can affect you in your brain. I remember a young fellow saying to me, he said, but Dr. Kennedy, nothing bad happened to me in my childhood, so I'm really, really guilty about putting this on my parents. But he actually had a very strong family history, and he was beginning college, so there was a change. So sometimes it's the combination of a particular stress on top of a particular vulnerability. But he did well and went on to do very well. So low mood can be a normal reaction to certain stressors and life events, and it might take a few weeks to get one's head around something. Grief, normal. I always think, why are we back in a few days? Yeah, sure, we're back in a few days, but I mean, you don't stop missing somebody in a matter of a few days. But then the psychiatric syndrome, which we're talking about, is a depressive disorder affecting your functioning, affecting more than 3 of those symptoms for 2 weeks or more at a time. So a clinical assessment depending severity and duration of signs and symptoms. They say, I think that's evening out now more, you know, because men in the past have tended to take alcohol, drown it in different ways. People with childhood adversity are more susceptible to anxiety and depression. Again, that can lead one to have an approach of whether it's drugs or whether it's talking therapies, because learned patterns have to be unlearned. If I think every time I have a stress, I get into bed and lie there, well then that I may have learned. So the unlearning of that becomes very important in treatment. Whereas giving a heavy dose of something which leaves somebody sedated and more sedated is not the best way. Maybe a small part of something, but it's not the best way. Anxious, impulsive or obsessional traits. And we know sometimes we try to keep safe by doing cleaning, you know, by trying to keep safe, not be contaminated. And that can become a problem. And again, going back to that fear driving the obsession, a cognitive behaviour therapy strategy would be better there. even though SSRIs or serotonin uptake inhibitors have been shown to help. I've had, childhood trauma and people with terrible intrusive images. And there is some evidence that something like mirtazapine, which helps sleep, decreases the intensity of the images. So maybe then we can do the therapy without agonizing somebody, because you have to be aware as well, can I tolerate this? Teaching people when the distress comes, can I have, and that's if I'm impulsive, I go from 0 to 100 really quickly. Can I understand that? Can I get skills to know that I can bring that down? My mind can bring on a panic attack, just as with therapies I can self-soothe, I can self-care. It doesn't get rid of the original problem, but it brings me back into a sense of control myself. It's more common, it says single, divorced or widowed. I think that's nearly everybody, at some stage. Married men have some protection, but single men tend to do less well, or those who have been widowers. And again, maybe that's indicative of our society, that people express things in different ways, and maybe it's a bit stigmatizing. And I like to see the sports guys and the Paul O'Connells and all that coming out with sharing, and the GAA, their expression or their experience of depression, because we have too many young men and older men who think it's failure and shame, and then that locks in that thinking. So is recovery possible without medication? This was a focus group I had, but it takes longer, it can take longer, take years. One lady said, it's like a crutch. But if you're so far down the bottom of a hole in the corner, it's meant that I can gaze up and see the sky. But it took me 2 years to take the medication. I thought, well, maybe there's a stigma about medication as well. I know what I should be doing, but you don't do it. It becomes overwhelming. How to break this down. It's good to know you're not the weirdo in the corner. So, it's common. Treatment with antidepressants show a third of people can get to complete remission, a third show partial remission, a third fail to respond. Now look, there's a lot of pros and cons in an awful lot of these studies. And some people say pills bad, talking therapy's good. The Lancet, which is a reputable journal, in January last year, managed to do a meta-analysis looking at, putting together a whole load of trials on 21 different antidepressants. And it had previously done one on 12. And it did show that antidepressant work moderately. It wasn't a massive, strong effect, but they did work, and they worked better than placebo. If you Google Lancet 2018, it'll pop up for antidepressants. Interesting, a lot of stuff, do you get side effects? You do. So who drops out, who doesn't? Why do placebos work? Was it because they were all double-blinded, randomized controlled trials? In other words, the people taking the thing, the substance, the people measuring it didn't know whether this was an active ingredient or not. So perhaps sometimes the people with placebo thought they were taking something. So there's all of that in it. But, there were things like 1.5 times odds ratio that it would help. So again, they can help and they can work, but not for everybody, and there are side effects. So another trial looking at medications was the STAR-D, which, for example, looked at citalopram or Cipramil. In pure form is Lexapro escitalopram, American Journal of Psychiatry. Now, why we take that is because a lot of docs look at that as its outcome, because again, 2,876 people, 62% psychiatric care for up to 15 years. So it wasn't a simple, straightforward, once-off depression. And 75% had recurrent, it was coming back. And we know sometimes if you take 2 antidepressants, is it resistant? And again, they're not blinding. They're not blindingly brilliant results. However, people did remit. In other words, the thing is, these studies are only also for 8 weeks, so they're not long enough. But the remission rate, 27-28, did well, taking about 6.7 time to response. Now, what does that mean? That's kind of takes a little bit of time to look at. But it's where we would say, and when we're trying to look at algorithms about what works and what doesn't, We try to follow the evidence where one has it. One doesn't always have it, and each person is different. So citalopram worked in 28% of the outpatients with this major depression going on for years. But if it didn't, in the others, it failed. Sometimes you could either switch to something like venlafaxine, and another 24% improved. Bupropion, Zyban for anxiety, 21% did. Sertraline, Lustral, 17%. Or you could add in bupropion or add buspirone, and then you move things up to 30.1% more. And then what some people do, and you'll know with doctors, can augment, and they might add lithium, 15%. T3, which is thyroxine, used to be all the go. And then we thought, oh, that's kind of weak, not really working too much. But this study found another 24% improved with it. Nortriptyline, an old-fashioned tricyclic, which was considered to be the gold standard, improved another 19 point something. But of course, tricyclics cause constipation, they cause dry mouth, they cause a bit of sedation, they might cause eye problems. Now, the drug companies push the SSRIs big time, and sure, they don't give you that, but they can give you overactivity. They can give you, in some people, and young men, I've seen that, excessive activity. So they've got energy, and that's where I say watch out in the first couple of weeks, because you might have energy, but not a better mood. And if you've had suicidal ideation, that can be difficult, because it's very hard. So I say watch out for those periods. It's not that they cause it, it's that you're having it, and suddenly you have the energy, sorry. But again, they can work. So you've got an overactive person, you might give them the nortriptyline to calm it a little bit. Mirtazapine, 12.3, Zispin. I find that very good in PTSD. When it's added into venlafaxine, it's called the Californian cocktail. As one of my patients said, you know, she got a lift, sure, but she said, how depressed can you be every morning? She's, you know, finished work in 4 hours and she's looking at the Golden Gates and the sea. And I said, well, actually, you can be, but the Californian cocktail is working. Tranylcypromine, you know, the old MAOIs. I don't so much like to do them, but they were useful for people who had maybe oversleeping, the opposite, and not less sleep, oversleep, overeating, personality maladaptive things. They do the opposite to what you'd expect. But you have a lot of dietary restrictions. So then they said, well, look for something, Rema and meclobamide, which is exactly the same, but you don't have the dietary restrictions. It's nearly exactly. It's a purer form. But then they processed it and got that on the market, and they did it probably it's terribly mild. So it'll work in some, but not in others. And, you know, and then 30. But basically, I suppose what the STAR-D trial said was that if you followed through, where you may have, you know, these biological features of depression, you'll have people who also, it's going on for a while, you want to try and see, can you lift mood by any means possible? You want to give them that leg up, that if you follow through on this sensibly, now I don't believe in giving a bit of this and a bit of that and a bit of the other. It might work, but you may lose track of where are we on the evidence base. So we try, insofar as we can, to follow, you know, what has been shown in trials to work. And be honest with people. My goodness, if it takes 6 weeks and I have to switch, and 6 weeks I have to switch, and 6 weeks I have to switch, you can imagine you need a lot of support and hope and working it through. But that was for the more severe end of the spectrum. I've had loads of people who have done well, but nobody has tried them on. I remember this young gentleman very well. He had about 3 years of panic attacks, anxiety. Of course, he did loads of therapy before he went to he didn't go for interviews because he'd be so anxious. He was low. And then I was listening and I was thinking, this guy is a brilliant coper. You know, he's trying everything. His mother he and his young wife were looking after both sets of parents with illnesses and had a young baby. And I thought, this guy has plenty of resilience. So I asked him about his father, and his father had exactly the same pattern, but used to drown it a little bit in drink. So I said, you know, I'm looking at something that probably started as a social anxiety, youngster, 14 or 15, but actually grew into this consistent avoidance and depression and mood. And I just gave him an escitalopram, and I promise you, he didn't think it would work, but 6 to 8 weeks, he was fine, and he was so sorry that somebody hadn't tried it for him earlier. So again, everybody is very, very different. Behavioural-based non-drug treatment. What do you think of talking therapies?
Sounds
Why would they sound good?
Because you're letting go and you're being open.
You're,
Being open.
yes, exactly, you're being open.
You're relating.
Yeah. You're open and relating, yeah.
You're finding the cause of depression.
Yeah, and that's an important thing, isn't it? Because sometimes, you know, we may have some people who there isn't a cause, but other times, and I keep saying, why now? Why now? Something is triggered, something has come, something one is facing. So you may find the cause, and that's terribly important, actually. Yeah, anything else?
It's like medication as well, because the way you have to find the right medication, sometimes you have to find the right therapist as well.
Absolutely important. Absolutely important. And I think that's one of my bugbears, because I know, which is true, that in the country they say we're going to regulate therapies, which is important, all right, or at least that whoever is going to has some training and skill in it, because there are an awful lot of excellent therapies and an awful lot of excellent therapists, actually. But I have come across in my work at times things that really frighten me. And I realise that somebody who hasn't any particular training has something that they're projecting onto the patient, you know. Maybe they had a bad experience with an alcoholic dad, so you must leave this situation right now, or they impose, because if you're not trained, well, then you're dealing with strong emotions, and strong emotions will have some effect on oneself. That's where the training comes in. What's the transference? Use it positively. I may not have experienced that, but something similar, so I can be empathic. But I have to watch out. I may have somebody who's training with me and I teach them, hopefully, to be reflective about their own feelings, because they might say, well, look, I'm great with X, Y, and Z, but don't give me anybody with alcohol because it's just too strong. Or I remember when I was training, and you know, you work in forensic and you had to learn. And most of us found something like a child murder so difficult, because you still have to assess what is happening here, and you cannot have your own emotion projected onto, you know, that terrible feeling that you know, feel of anger or whatever it may be. So it's very important to get the right person for both, because we're all not like, you know, we don't rub off each other easily. It's going to be a very powerful tool, but it has to be safe, it has to be trusted, and hopefully it has to have an evidence for work. So I think, as we say, being open, yeah, and we know where we feel safe and open to. Relationship. Again, you know, you could have, and it could be a young SHO or somebody who's good. But I remember when I was training, they were saying, well, remember to work with exit. This therapy will come to an end. Therefore, you must model for the person the fact that you care, but that the therapy will end. So they will acknowledge a certain grief, know that you care, but be able to move on, because it's a therapeutic relationship, not a detached one as such, the therapeutic one. And that's very powerful. Again, I remember when I learned that, because we're always moving when we're training every 6 months, and I remember somebody who had done well with me, who was a powerful, powerful self-harmer. She really, and she would be so powerful in it, just when you think something is grand, go out the door and then do something. So it was very difficult for nurses who were long hours with her. And it came to March and I was leaving in June. And I remember we had our own supervision with a therapist. And she was saying, and I was saying, well, what about X? And then I was saying, well, you know, this nurse is very good, this nurse is very good. She said, no, stop, why are you saying that? Have you told her yet? Because if you don't tell her yet, she'll think the first person, I said, I like her. She said, yeah, she'll pick that up. So the first person that actually liked her hasn't given her the respect of saying, well, I'm moving job in June. You must do it. I thought, oh my goodness. So I did. And the anger was huge, and it rained down, and how terrible I was, and disappear, might as well change now, etc., etc. And I had learned through the therapy supervision to hold that strong, powerful emotion and where that might be coming from. And so she came back after 3 weeks, sat down and said, well, okay, so if we only have this time left, what are we going to do with the time left? And in fact, it was a much more powerful intervention, because she had she knew something was going to end. She had the respect of knowing that. She used the time. She got knowledge of her own emotions. And I was not the terrible experience that she had in childhood of somebody who, while they were supposed to care for her, had ultimately hurt her in the worst possible way. So that's where I come in, that, you know, I'm very, very strong on that. Yes, there are different therapies. CBT will work for anxiety disorders and OCD very well and all of that, interpersonal for grief and so on. But actually, people are too important to just think any therapy will do. It has to be suitable, and again, who you both trust. So they're different ones. Behavioural activation, CBT, interpersonal psychotherapy. They're the three that in England, the NICE guidelines that say they're evidence-based for depression. Yes, they work. But, you know, sometimes things are a little bit more complex than that. Somebody said about alternative ones. Mindfulness, bibliotherapy, nature, role of the environment, creative arts, music and art. Terribly important. You know, I remember when I was working at one stage, we were able to refer books, and some people we were actually prescribing books, and that was great. People got them. The health board paid for them. Them were the days. But actually self-help people worked it through, thought about it, came back and asked for it, asked for help, and, you know, and it can work. Mindfulness, as we said there as well. I'll come back to the nature, role of the environment. And again, I've worked in so many places around the country at various times over the years. And sometimes I sit somewhere and I think, do you know what, I'd be really depressed if I was actually coming in here and having to talk about my problems. I do believe in light, and I do believe in our environment. I do believe we should be advocating for services that actually have green, you know, that are respectful across the way. Remember a man with dementia and depression, and he was sitting in the middle of a very busy Dublin hospital saying, "Why did you put me in the supermarket, doctor?" And I was looking around, and there was trolleys and everything. You know, how are you going to get better there? I don't know. So behavioural activation, that was basically things like life events. Things can happen, get sad, tired, worthless, stay home, stay in bed, watch TV, withdraw, ruminate again and again and again. Loss of friendships, could be conflict with supervisor, financial stress, poor health. And I don't mean just on a bad day. I mean this has taken hold to the point that the person is suffering from depression. So that's like what I was saying earlier. Having a nurse, a therapist, somebody to look at what's my mood, to do a date, how you feel, what can I go? I made a cup of coffee, that was good. Not I ran down the road and did X, Y, and Z, fix the socks drawer, but we begin to actually break down small goals and activities to break the helplessness. And that's terribly important because it does build up well. And the studies for that, again, they would be available through Aware and the website with this. Various studies, some older ones, newer ones, about behavioural treatment for major depression disorder, which again works. CBT, many people will have found that helpful. And what is it? Reduces emotional reactions and self-defeating behaviour. Now, Beck started it back in 1976 or more. And I admire him. I heard him speak, and he said he'd been using group psychoanalysis for years, and then he thought, do you know what? The people who drop out are doing better than the people who stay in. And he looked at it, and he looked at the suicide rate, and he was already in his 50s. And he said, actually, what's happening is I'm finding the cause, but I'm not leading to a way forward to manage the present. And that is a very powerful thing about CBT. You understand the past in order to manage the present. So I might think, you know, I always think the simplest, mum goes home and the kid has thrown the clothes on the ground, and some people think I'm a very bad mother, others think, oh, that's my Johnny, he's exactly like that, here he goes, I'll have a job with this fellow. Very different, because one thinks I'm never a good enough mother, and this is the standard. And somebody else thinks this child has some responsibility for his own stuff too. You know, so CBT looks at our negative automatic assumptions about ourselves. It's collaborative, active, open-ended questions. You know, why? What would that mean to you? What would that mean to you? What might be going on for you? It's very structured, very focused. People who like structure and focus, that helps them, that works. So, you know, on the environment, you might have thoughts, I might crash, then I feel anxious, then I seek reassurance. And the more you seek reassurance, it only lasts a couple of minutes. The next minute you're off feeling heart racing, palpitations, rapid breathing, choking. So we might go after the heart racing and do the breathing and break it. We might look and challenge the thoughts. Yeah, 90% I might crash, but maybe 5% I won't. We might actually look after the behaviour. Now, I won't ask about reassurance. I'll sit and I think I'll probably panic and pass out, but you know what? I'm still alive here, so that I get a little agency around myself. So with CBT, we commonly look at the thoughts. I'm worthless, the future is bleak, nothing will change. Anxiety, I'm in danger, something terrible has happened, I can't cope. Anger, I've been disrespected, it's unfair, I won't stand for it. Very powerful thoughts. We are very powerful, but a thought isn't an action. A feeling isn't even an action. So with CBT, over 14 to 16 sessions, beginning to break it down, beginning to break that cycle, works extremely well in a lot of people. Interestingly, I found when I was studying or training, it didn't immediately work with people that I was looking after, and I feel that was because their mood was already so low and their emotions were really so overwhelming that I had to give a language around emotions. And that's what led me to move into interpersonal therapy and get trained in that. So again, you know, different strokes for different folks. Negative cognitive triad. A negative view of oneself, a negative view of the past. When you're depressed, it's only the negative. Do you ever feel then when you're out of the depression, you remember a good day? Not everything was bad. And the future. How to break that. So CBT can work through self-help. You know, there's lots of CBT self-help books. I say to people, look up, I should get royalties for CBT for dummies. But it's just that negative. You begin to say, oh, no, I'm thinking about that automatically. And you hold it and change it. Some people like the computerized ones, you know, the blues, beating the blues. Psychoeducational groups, CBT for depression and anxiety. Complex problems, CBT that's developed now further to involve some aspects of psychoanalysis. Schema therapy. Somebody might go to in their same day, I'm angry and critical, I'm sad and helpless, I'm a childlike, I'm aggressive. And there are all these ways we've learnt or may have learnt, and this schema therapy can really help. Now, it's a 2-year influence, but the outcomes are very, very powerful for people who previously had been in and out of hospital for a very long time. So there are all these various ways. You'll know a lot of people here. I'll just fly through the next few because I want to do a little bit about music. Interpersonal therapy, it's on attachments. Where do things start? You know, postnatal depression, what was that? Attachments. Interestingly, there are studies saying people who do psychiatry, that a lot of them who do old age psychiatry, and I'm a dual old age psychiatrist, have good relationships with their granddads. You know, and it's kind of what you model and who you want to help. Others that psychiatrists, they have a bigger group of people whose mothers had postnatal depression. So, you know, you model certain things. People who've had a loss of a parent before the age of 12. Now, Brown and Harris have studied that. Now, in essence, later on, you can experience distress as loss. And so you're experiencing loss, and interpersonal therapy does really well there because you're looking at loss. And you're modelling your symptoms and seeing how could we look at that differently? Is there a way we could communicate that differently? What could we do to learn how to communicate that differently? Conflict, all of that. So we look in a way which enables a solution, which is also helpful. Grief, transitions, disputes, sensitivities. That's what it has. It has a very good evidence base for grief, transitions, disputes, less so for sensitivities. And sometimes I find for living with sensitivities and that deeper trauma, maybe schema therapy, dialectical behaviour therapy would be better. Time's up, I'm through listening. Now, that's not me here, but it's this, you could say that. But actually what I mean by that is sometimes people have the same conversations for a very long time. And what that might mean is actually what we need to do is target a talking therapy that's specific. Behavioural activation for goals of depression, interpersonal for the interpersonal relationships environment, CBT for my thoughts and how they influence mood. And they're time limited, so people do get better. So which comes first, the chicken or the egg? The direction of the cause of depression can be difficult. It impacts on people around them. People might be supportive, but negative feelings in interactions, they feel frustrated. And family and friends may be exhausted. So it's okay to go for professional help and seek that and look for an education session with family. It doesn't mean they don't love, but they have a different language. You know, somebody says, I've done everything for you. So maybe in their idea, if you do everything for somebody, they should get better. The other person might think, I just need you to listen to me. There's different languages of what that means. So there is evidence for psychotherapy, but there are side effects. In other words, I've had people who have been re-traumatized. They've suffered so much trauma that I'm teaching and we're going through skills and how to manage that. So one has to be aware. You don't go right back into something if it's not safe. And Beck learned that in his looking at CBT, because he said he was looking back in groups at something but not giving people current tools. And people are resilient, and people do come through a lot. And there is that kind of narrative in there that's but there's huge benefits as well, because what I would say is that while you can get a leg up and get going again with medication, perhaps, actually sometimes with CBT or IPT, behavioural activation alone, in order to stay well and maintain it well, you have to, as we said, know the cause. You have to learn perhaps a language around managing and coping and linking with the symptoms. And you may have to enact changes that mean the environment is going to be better for your mental health. So nature, there's a role for the environment, isn't there? Nearly coming to the end. But Shirley Gleason is somebody, again, if you Google her, Shirley Gleason in the South Dublin now, she does a number of groups, forest walks and so on. And interestingly, she did her diploma on which of those do you like best? Most people like nature. I think the nature is beautiful. I have a young, lively secretary, and she said, oh no, I much prefer the one on the right. It means there's something going on somewhere. So there you go. But anyway, for many people, nature, the social work concept of the person in the environment, understand the individual and the environment. We all know, do you know what, that environment is toxic for me? It could be a workplace. It's usually to do with your core values in some form. So we need a fit between the individual group and the places we live out our lives. And that's all systems theory. So there is an evidence for that. And again, you know, therapeutic landscapes, green gyms, ecotherapy, conservation projects, therapeutic horticulture community, healing gardens. And sometimes doing these things, it's not just, and it can be good because you're social or you're with others, but you're not concentrating on the problems, you're concentrating on the gardening or whatever. But it is also that, and research would say, it decreases the ruminations. The ruminate when you're depressed. It's round and round and round. You can't get out of your head. Somehow there's something about forests, there's the green, something bigger than oneself. As one girl said to me, just was such a relief to have something bigger than my head around. So there is evidence for supporting the role of nature in mental health. An RCT by Bratman, contact reduces rumination associated with anxiety and depression. Rumination is. So nature experience can block or counteract that, reduce the risk of developing mental disorders. So now I'm going to move on to, as well, last couple of slides. One of them is that, again, I think older people can suffer from depression, and people too easily will say, oh, well, actually, that's understandable. You've lost this and you've lost that and you've lost the other, but they don't get psychological therapies offered to them. They don't get alternative therapies sometimes offered to them because it's understandable. But just as it's understandable doesn't mean that it won't respond to treatment. Now, if somebody with Alzheimer's disease, 30% suffer from paranoia, depression, anxiety. And I mean, the last thing you want in the middle of this, not knowing what's happening around you, is to feel that, in fact, low. And so many times we only are looking at behaviours, whereas in fact a lot is coming out now on the mood, the quality of the mood, that the moment is what counts and you want to make each moment count. Music is powerful, there's a lot written, and today isn't the day so much for going over it, but there's a huge amount on music therapy. At the moment we're involved in our area with looking at, is it drums therapy versus group therapy, music on the one-on-one, the use of a therapeutic choir, where people, the carer or the spouse whose loved one has dementia, might be the first time they're doing something together again. So Melissa Hirokawa, if I pronounce it, sings to a Happy Dorothy's end-stage Alzheimer's disease.
I bet a fella or two has made eyes at you. Is that true?
Yeah, she's a little old romantic, that one.
I believe it. Let's do that song. Ma, he's making eyes at me. Ma, he's awful nice to me. Ma, he He's making eyes at me. He's awful nice to me. He's almost breaking my heart. I'm beside him. Mercy, let his conscience guide him on. He wants to marry me. Be my honeybee. Every minute he gets bolder. Now he's leaning on my shoulder, Mom. He's kissing me. Dorothy, if he was making eyes at you, what would you do?
When you look at that, you can see she just livened up, didn't she? She just came alive. She starts to tap, she starts to interact, she starts to look. I had a gentleman with frontotemporal dementia. He hadn't spoken in 5 years, very little. He had the side effects of medication, of dribbling. And I got this young lady who had, she was working with a group called Music de la Santé, who are trained in empathy and trained in music. And she began to sing a music of a kind of song with the lyre from the 14th century France. Now, he was from West Waterford. And he just literally started to sing along, and he went like that and said, "That was beautiful, thank you." He was like a ballet dancer. And there was something in his brain that reconnected, and he stopped the dribbling and stopped the side effects. He wasn't anxious anymore. And that, it's a power. That is a power of another part of the brain, which I think we really owe our patients. What about the forest streams? I won't be long at this one, but just as that, how do you feel when you're watching that? How did you feel watching that? Bit loud. Very relaxing. And again, if you're in the middle of that for a couple of hours, yeah, the sound won't be as loud as that in the middle of bouncing off a wall. But actually, again, the power of that very much to help with things. So creative arts, mindfulness, bibliotherapy, lots of things. Art itself, as we're saying, alternative ones. I show this before to people. It's 9 foot high and across, and I think it might still be in Clare Morris Museum or our local community centre. 8 people with schizophrenia and 8 people with social problems. In the days when you could ask your health board for money for art, I got 2 art therapists from Italy to come. It was lovely. And all I remember, and it keeps coming through my head, is a gentleman who had depression along with his schizophrenia. And he couldn't get out of bed, he had negative symptoms. So a nurse would go and help him dress, and that was fine. But you're talking about 20 years. And he participated in this Greek mask. He did one of the panels here. And, was it the togetherness for the week? Was it the understanding that the Greeks hid their mood behind this mask? Was it the language that we gave him? But all I know is he rang us in the centre at the end of the week, and he said, "Can somebody come out with me? I want to buy a new set of clothes." He came to a session, he came to a nice reception we had, and I remember his smile. It was a spontaneous smile, his new suit beside that, and he got into art from then on. I use art a lot because sometimes the non-verbal gives an expression of things that we didn't even know we were experiencing. So again, the power of relationship, the power of connecting with each other. And above all, I keep saying what is this debate? I use whatever works, get a good assessment, a good treatment package, take somebody who works with the evidence, because people do get better. And hope is vital, because hope is also that there is something beyond here, which is better for me. And so many people I know say, well, look, I wouldn't wish it on my worst enemy, but what I've got through it is something quite different now. And that is the sense of enjoyment in that cup of tea, or knowing your cow, or knowing the moment, or that I am actually worth it. So in that sense, I would say thanks for your attention here. Sorry for keeping you over, and I'd be very happy to take some questions as well. Thank you. Thank you.